Assalamu alaikum and good evening to you all. Welcome to the fourth episode of Health Talk. Health Talk is a health educational program organized by ACP Bangladesh chapter and supported by Bangladesh Society of Medicine. As you already know, in each episode we try to bring someone very special as a speaker and learn many important things from them. Today I am very excited because we have so many stars here with us. The speaker of today's program is someone who needs no description at all. He is the inspiration of so many young doctors and he has been my inspiration since I was a medical student. He is none other than the current principal and professor of medicine of Dhaka Medical College, Professor Khan Abul Kalam Azad sir. He is also the former president of Bangladesh Society of Medicine. He will be discussing on current issues in medicine of 2020. As the chairperson, we have someone who is considered as the best physician in the world. My direct mentor and my idol, Professor Qazi Tarikul Islam sir. He is the professor of medicine of Popular Medical College and immediate past president of ACP Bangladesh chapter. He was also the former president of Bangladesh Society of Medicine. As the chief guest, we have the renowned professor of medicine, Professor A.K.M. Aminul Haque. He is the current treasurer of ACP Bangladesh chapter and vice president of Bangladesh Society of Medicine. Today's program will be moderated by our very own Dr. Shormishta Bishwas Madam. She is the secretary to the governor and associate professor of medicine, Dhaka Medical College. During the live session, you can ask topic related questions in the comment section. We shall try to answer them on the question and answer session, which will start right after the presentation. So without any further delay, let me hand over the session to Dr. Shormishta Madam to moderate today's program. Dr. Shormishta Madam.
Thank you, Dr. Prince. Honorable Chairperson, Professor Qazi Tarikul Islam, today's chief guest, Professor A.K.M. Aminul Haque, today's speaker, Professor Khan Abul Kalam Azad, and learned viewers, good evening. As you have heard, this is the fourth episode of Health Talk that is organized by ACP Bangladesh chapter and supported by Bangladesh Society of Medicine. Thanks to Bangladesh Society of Medicine for their generous support and cooperation. So let us start the session. Today, we have got a very eminent figure in the field of medicine. Our very dear sir, Professor Khan Abul Kalam Azad, Principal and Professor of Medicine, Dhaka Medical College, and former President, Bangladesh Society of Medicine. And our today's topic is very interesting and very important. This is the recent advancements in medicine. May I request Professor Khan Abul Kalam Azad to deliver his speech on the topic. Sir.
Thank you very much, Professor Sharmishta, and thank you for the kind introduction. First of all, I'd like to give thanks to the organizers and especially Professor H.M. Nazmul Hasan, Honorable Governor of SCP Chapter Bangladesh, and also who is sitting on the chair of the session, Professor Qazi Tarikul Islam, former Governor of SCP Chapter and the first ever Governor of Bangladesh Chapter, Professor Qazi Tarikul Islam. And also I find a very near and dear person as the chief guest, Professor A.K.M. Aminul Haque, sitting with us, and also I find so many students are there who are linked with the session. And today, truly speaking, the chapter which has been given to me to discuss is a new type of lecture, what I believe, that so many advancements are going on, and they are the current issues. Some of the issues are there, for one decade or more, they are being practiced or being given to the patient, but still there are so many researches which are going on the issues, and we'll talk on some of the issues which are very important, and a doctor, a specialist should know about those advancements as the current issues. And truly speaking, it's a very vast world where you can find thousands of research works are going on different types of diseases or status. But the thing is that we could bring some of the issues to discuss today. And today I have brought three issues to be discussed. with the student. Number one, the ischemic stroke management. That what is new in the treatment of stroke and what is being practiced in the world in the last several years, and what we should do in our country, whether we are practicing that in that management of acute ischemic stroke. What is the better outcome in those patients with the a little bit modern type of treatment? What are the limitations of those type of treatment? That I will try to focus on. And the issue is acute ischemic stroke because it's a very common condition in Bangladesh. And the second one, we know that atrial fibrillation, where we can find the disturbances in the rate and rhythm in the myocardium. And so we can say that the patient can have your myocardial disorder like myocardial infarction, the patient can have atrial fibrillation. And very importantly, if the patient has got dysregulated rhythm, he can have stroke. Again, the question of stroke comes with relation to atrial fibrillation. And the third issue, you know that diabetes is a disease which is there prevalent in every country in the world, and newer type of treatments are being available, especially the oral formulation. And I have selected one topic, the sodium glucose cotransporter 2 inhibitors in the management of diabetes, and what is the health benefit of this type of inhibitors along with the management of diabetes. So with the permission of Mr. Chair, and I like to go to my first topic and the update on treatment of acute ischemic stroke. Honorable Sir, we can find that the global burden of stroke is really very, alarming. And we can find that this in this session, we are sitting, almost everybody is over the age of 25. And it has been said that 1 in 4 people over the age of 25 will experience stroke in their lifetime. And you see that new strokes which are occurring globally, 13.7 million people are having stroke. And we have seen that 80 million stroke survivors are worldwide, and with a death rate of 5.5 million per year, and 116 million healthy years of life lost to stroke each year, along with the financial and economic burden, psychological distress, and so many other things. So we can say in a single sentence, stroke devastates lives around the world. So Bangladesh is no exemption, and we can find that the burden of stroke in Bangladesh, we have got number one cause of disability in Bangladesh, and above the, we can find that in young people also below the age of 40, we have seen that 12% of the people can have this stroke below 40 years of age. That means stroke can occur in younger people. That is also one of the important issues. They can have the primary disorders which can lead to stroke, especially ischemic stroke. So that is one of the important issues to be discussed. And we can find that in Bangladesh, it is the third leading cause of death. So it is so much alarming, Mr. Chairman and learned audience. We understand that how much important it is to discuss about the modern treatment of stroke in our context. And the clinical management, we know that there are so many attempts, so many things are there which are being tried in patients having stroke. Number one thing is that when the patient comes to the hospital, most of the patients in our context, we manage the patient in the general ward. And this is a very important issue, Mr. Chairman, sir, because in the developed world, they have got the stroke units. And in the stroke unit, a separate type, a distinctive type, a very better form of treatment is provided to the stroke patient. It means that, for every 10,000 person, about 50 patients survive from a stroke if they are managed in the stroke unit. But in our country, we don't have a stroke unit. Rather, we give the general supportive treatment to the patient, and we find that the most of the people they can have respiratory cardiovascular complication. So we treat all the types of complications in those stroke patients, and also we try to focus on the etiological factor. We find that the patient can have hypertension, the patient can have diabetes, the patient can have dyslipidemia, the patient can have obesity, and so with those features, we treat the patient with the supportive care. We take care of the patient's nutrition, hydration, prevention of infection, then rehabilitation and others. So that is one of the areas where the concern was to the researchers that what better thing can be done to the stroke patient. So there was no specific therapy, and in case of your evolving stroke, and we in our clinical setting we find that many of the patients they can have evolving stroke because they come a little bit earlier, but we just observe and we just give a follow up, we monitor the symptoms, and this just we see that this is the case of evolving stroke. Okay, let's wait and see what happens. So another important issue was there whether the patients who are having some of the alarming feature or the features we can direct towards the evolving stroke, whether they can be transported within a very short period of time to a hospital. That is a very important question, and nobody emphasized on that issue because many of the patients they attended after having some form of your physical disturbance in the form of your muscular weakness or speech disturbance or visual disturbance or your orientation, they were sent to the local hospital, which was really very area where there was no CT scan or there was no care of that to follow up the patient to give a good monitoring supervision. So there was a delay to transport the patient to a tertiary level hospital. So on most of the occasion we find that there was little emphasis and there was no urgency to transfer the patient to a tertiary level hospital. So we are treating the patient with your antihypertensive, anti-lipid treatment. Then we are checking for the myocardial involvement or something like that. But the thing is that for the last 1 decade or more, it is a very popular in many of the centers where there is reperfusion therapy, though it started about 30 years back. Because when we had the experience of treating the myocardial infarction patients with reperfusion therapy, so the similar type of involvement occurs in case of your brain parenchyma due to vascular occlusion, where there is your ischemic stroke. So the question of reperfusion therapy came into the scenario, and so the fibrinolytic therapy offers the healthcare providers an opportunity to possibly limit the extent of neurological damage and to improve outcome in stroke patient. So this observation, as it came from managing the patients of acute myocardial infarction, so many things will be there when the patient will have equal benefit in the heart and in the brain when we treat the patients with this type of treatment. So but the thing is that one important very constraint is that the patient should be transferred to a specialized center for reperfusion therapy within a very short period of time. And the time available for treatment is very limited. So early recognition of stroke, rapid trials, evaluation in the emergency department, and definitive management are essential. I will show you in a next slide that how important it is to transfer the patient, how important is the preparedness of the hospital team to receive the patient and give the appropriate treatment, Mr. Chairman, sir, and the learned audience. And we know that stroke therapy requires this reperfusion therapy. And this reperfusion therapy has got the benefit that because, we understand the occluded vessel, there is an area of ischemia. And around that ischemia, there is your penumbra where there are some viable neurological tissues or the neurons. So we have got the idea that immediately if we can recanalize the occluded vessel, so we can improve the ischemic tissue by oxygenation. So that is very important. And also, we can optimize the collateral flow, and secondary brain injury can be avoided or prevented by that. So, for acute ischemic stroke, there are so many papers which are published by American Heart Association, American Stroke Association in 2019, and in the continuum in cerebrovascular disease, we have seen that prompt reperfusion is the most effective treatment for patients with acute ischemic stroke. That was their conclusion. And as I mentioned, the ischemic penumbra is a region of hypoperfused brain that can still be viable with prompt recanalization of the occluded artery. That is very important. I want to mention, Mr. Chairman, sir. So this endovascular type of treatment for recanalization has some strategies. They can be done either single or in combination. The most important is that intra-arterial fibrinolysis, and also in some patients we can go for mechanical clot retrieval when the occlusion is very big, and we can remove the mechanical clot from that by thrombectomy. And in some cases a separate type of thrombectomy is done by suction, and in some cases there may be primary stenting to just improve the circulation or the blood flow through the occluded artery. So this is the picture where we can see that the recombinant plasminogen activator, which is given intravenously in a patient after the patient is received, and in the same patient, intravenous recombinant plasminogen activator, which is being diagnosed by CT perfusion imaging and the CT scan, and then we can give this intravenous recombinant plasminogen activator, and then the angiography is done to find the extent of the occlusion. Then we can go for the DSA, and then we can go for endovascular thrombectomy. That is the usually sequence when we say that there may be a combination of some procedures together, either by chemical thrombectomy and the mechanical thrombectomy, Mr. Chairman, sir. And so, as I mentioned, many of the patients, they require your combined approaches. When we start IV fibrinolysis, that initiates reperfusion rapidly. And then we go for debulking large proximal thrombi by mechanical endovascular treatment. And very importantly, and sometimes that the local site intra-arterial fibrinolysis can be done in case of your distal elements, thrombus elements and emboli, to clear those residual elements, Mr. Chairman, sir. So in the same patient, by giving IV fibrinolysis, we can go for further approaches stepwise by mechanical endovascular debulking and intra-arterial fibrinolysis. That can give a good expectation that we can clear the thrombus, and we can recanalize the vessel, and we can reperfuse the ischemic area, and thereby the outcome is better, and the residual disability is less probable in those patients, Mr. Chairman, sir. So this is very important slide. What I want to mention, Mr. Chairman, sir, when we find a patient is having suspected stroke, he should visit the hospital within a very short period of time to become a candidate for this type of your reperfusion therapy. That is very vital. As I mentioned, Mr. Chairman, sir, just a moment, sir, a little bit disturbances. So that is very important, Mr. Chairman, sir. We can see that if the patient appears in the hospital within less than 4.5 hours, then we can go for CT angiogram or CT scan, for instance. And if we see that there is no large vessel occlusion, we can go for chemical thrombolysis. But when the large vessel occlusion is present, then we have to go for combination approach, that chemical thrombolysis and mechanical thrombectomy. But if the patient comes a little bit later, that is more than 4.5 hours, then we have to go for that CT angiogram or CT. And if the patient has got large vessel occlusion, then we have to go for mechanical thrombectomy. And if the large
Professor
vessel...
Azad,
Huh?
will you go for show? Because just below there is an umbrella like something. You just no show. Slide show. Yeah, that's right. Thank you.
Okay. Thank you, sir. So we can see, Mr. Chairman, sir. So if the large vessel occlusion is present by seeing by CT or CT angiogram, then we can go for mechanical thrombectomy. But if in this patient, the patient has come late and the features of stroke are there, then we can go for an MRI, Mr. Chairman, sir. MRI, as we know, that it can give us a better picture in this patient. Right. I don't know what is happening here. So many, you
Close
see,
karo. আবার শোতে যাও.
এটা, এটা. So,
Yes.
as because we know in when there is, suspected stroke, and in CT scan the clear imaging is not possible, then we can go for MRI to better visualization of those areas which are being involved. And we can find the patient can have diffusion weighted imaging or by fluid attenuated inversion recovery. That can give us an idea that the patient has got an infarct, and we can go for chemical thrombolysis. So, Mr. Chairman, sir, so large vessel occlusion present or absent, so the type of treatment will depend on those features in the patient. So here we can find that how we can give this recombinant tissue plasminogen activator, the altiplase, and we have to give at a dose of 0.9 milligram per kg. Up to 90 milligram we can give in a patient, and it is to be given very slowly over 60 minutes. And in bolus, in 1 minute we can give the 10% and rest 90% in 59 minutes. And the patient should be in the stroke unit or intensive care unit. So very importantly, I want to mention here, Mr. Chairman, sir, the patient can have some form of hemorrhage. So that is one of the areas which is concerned. And so for that reason, the patient is to be followed up for severe headache, acute hypertension, nausea or vomiting, or may have a worsening neurological feature. On examination, we can find that. So immediately within that period, we have to discontinue the infusion. And again, we have to check by a CT scan whether there is any evidence of hemorrhage. And we have to measure blood pressure, and neurological assessment is to be done every 15 minutes. And during that altiplase infusion for 2 hours, then every 30 minutes for 6 hours, then hourly until 24 hours after IV altiplase treatment. So that is very important. That will give us an idea whether the patient has developed any form of pure hemorrhage or acute hypertension. And the blood pressure measurement is to be intensified if the systolic blood pressure goes over 180 millimeter mercury, and the diastolic blood pressure is more than 105 millimeter of mercury. We have to administer antihypertensive medication to reduce the blood pressure immediately, Mr. Chairman, sir. And also we know that the patient after getting this type of treatment may improve very immediately. So the thing is that the patient is to be kept without any nasogastric tube, indwelling bladder catheter, or intra-arterial pressure catheters. And so if we see the improvement occurs within 2 hours, no need to introduce this sort of things, because the patient can have food orally and he can urinate and defecate with his own effort. And then after 24 hours of IV altiplase, we have to go for a follow-up CT or MRI scan. Then we'll start anticoagulants or antiplatelet agents, Mr. Chairman, sir. But the thing is that we can see here that it was published in 2019 and 2015, the two guidelines, American Heart Association guideline in 2019 and US FDA package insert in 2015 about the indication of tissue plasminogen activator. Indications almost similar, but the duration is less in case of your FDA approval, and where we can find 3 hours, and it is 4.5 hours in case of American Heart Association. And definitely the ischemic stroke with disabling neurological deficit is the main concern in this patient to be kept ready for reperfusion therapy. And also, you see this MRI imaging has been mentioned in case of your American Heart Association. I will say AHA, but in case of FDA, it is not mentioned. And they mention about the age, it should be more than 18 or equal to 18 years. And they, in case of FDA, they mention about warning for age is more than 77 years. But I want to show you in two slides, in this and the next one, the contraindication, and that is an area which is to be noted, Mr. Chairman, sir, because the doctors will be very eager to start this tissue plasminogen activator. Then they will have to consider this contraindication. Number one, head trauma within 3 months, ischemic stroke within 3 months, previous intracranial hemorrhage, suspected subarachnoid hemorrhage, suspected infective endocarditis, suspected aortic arch dissection, recent intracranial or interspinal surgery within 3 months, intracranial intraaxial neoplasm, gastrointestinal malignancy or gastrointestinal bleeding. Almost similar, we find that in those two guidelines, almost similar. Mr. Chairman, sir, in the next slide, we can see so many other contraindication: active internal bleeding anywhere in the body, systolic blood pressure if it goes above 185 and diastolic more than 110 millimeter mercury, bleeding diathesis if it is known in the patient, international INR, that is your 1.7. Heparin was given within 48 hours with abnormal activated partial thromboplastin time, or low molecular weight heparin full treatment dose within previous 24 hours. Platelet count is less than 1 lakh per cubic millimeter. Current use of direct thrombin inhibitor or factor Xa inhibitor with abnormal coagulation test, CT showing acute hemorrhage, and CT showing extensive hypodensity, that is more than 1/3 of the cerebral hemisphere. So that is very important, Mr. Chairman, sir. That indications we understand that we have to find out disabling stroke, and number two, within short period of time. But we have to remember about so many contraindications because the risk of bleeding is very high, Mr. Chairman, sir. So the recent considerations after this observation, that they have said it is also prudent not to administer IV thrombolysis in patients taking the novel and oral anticoagulant like dabigatran, rivaroxaban, and doxaban, because rapidly available tests in the emergency department cannot quantify the degree of active anticoagulation. So for that reason, the people who are taking this type of drugs are not the candidates for this IV thrombolysis. And patients with mild or rapidly improving strokes who present within the time window for IV thrombolysis and still have disabling symptoms at the time of the evaluation should probably be offered treatment with RT-PA. That is the recommendation which has been discussed in 2020 in Continuum in Cerebrovascular Disease, the journal. So we can find this is a very important message. That is the thing what we have to consider. And we have looked for the randomized controlled trials, and that is been there. That is Wake Up trial, efficacy and safety of MRI-based thrombolysis in wake up stroke. And these controlled trials have now established new indications for emergency reperfusion in patients with wake up stroke or delayed presentation up to 24 hours from last known well in case of thrombectomy. So with this knowledge of your chemical reperfusion, I'm trying to focus on mechanical thrombectomy. So it can be attempted when IV thrombolysis does not result in rapid clinical improvement, and also in patients who are ineligible for IV recombinant tissue plasminogen activator, Mr. Chairman, sir. So we are seeing in the picture left middle cerebral artery occlusion, then angiogram is done, and then we are going for coil retriever to be introduced over the thrombus side, and then it is retrieved by suction, and we can see that the access is done through the femoral artery, Mr. Chairman, sir. This is the mechanical thrombectomy device. This thing is being practiced in Dhaka Medical College also, Mr. Chairman, sir. So who are the candidates for thrombectomy? So this endovascular stroke therapy requires some of the indication like age more than 18 years, National Institutes of Health Stroke Scale more than 6, time from symptom onset to groin puncture less than 6 hours. I repeat, it's very important, less than 6 hours. And if it can be prolonged up to 24 hours, Mr. Chairman, sir, if there is evidence of sizable ischemic penumbra on perfusion imaging and good pre-stroke functional status of the patient, and Alberta stroke program early CT score more than 6 on baseline CT scan, and presence of proximal intracranial artery occlusion. These are the areas which are to be considered to select the candidates for endovascular stroke therapy. So this is the picture what I wanted to mention, Mr. Chairman, sir, that we can see that effective emergency service which is needed, that the patient he should recognize, and by seeing the warning signs in the house, emergency is called, and through the emergency the hospital is informed. The patient is immediately transferred to the rapidly to the hospital with pre-notification. That is very important. Then immediately in the emergency, the CT or MRI is done, and by the patient is transferred to the hospital and the OT, and the required treatment is done. So that is the thing. That is we call it stroke chain of survival. That is to be done in our context in the future to make people surviving. That is very important. So with these few words, I like to conclude here, Mr. Chairman, sir. So that is the area. I like to go to my second topic, that is rhythm control for high-risk early atrial fibrillation. Mr. Chairman, sir, we know that management of atrial fibrillation is an important area which is to be evaluated properly. We know that there is disturbance in the rate, there is disturbance in the rhythm. Definitely, we try to control the rate in case of fast atrial fibrillation. So, what is the significance of managing rhythm in case of your high-risk early atrial fibrillation? And there are so many cardiovascular complications. So that is very important, because before this, we'll find some papers that we have got a New England Journal of Medicine issue on 1st October that shows that because we did not have any idea that exactly whether rhythm control can improve the outcome in those patients having atrial fibrillation. And if it is done very early, then it is better, because we can avoid heart failure, we can avoid myocardial infarction, we can avoid the incidence of stroke, Mr. Chairman, sir. So we understand the loss of regular and organized left atrial contraction as well as the subsequent increase in ventricular rate lead to both immediate and long-term adversities in the health. And previous trials, including one trial involving patients with heart failure, did not show, Mr. Chairman, sir, superiority of rhythm control with antiarrhythmic drugs over rate control in patients with established atrial fibrillation. So that was the initial finding in early cases, but later our outlook was changed and our knowledge went beyond that. And then we see the East AFNET4 trial, the early treatment of atrial fibrillation for stroke prevention trial. That trial was planned by the Atrial Fibrillation Network, we call it AFNET, and the European Heart Rhythm Association. In 135 centers, Mr. Chairman, sir, 2,789 patients having a mean age of 70 with recently diagnosed atrial fibrillation, that means a median time period of 36 days from diagnosis, were randomized to early rhythm control or usual care. So initial aggressive rate control, and then another group with rhythm control for symptoms, Mr. Chairman, sir. And it was published in New England Journal of Medicine in 2020. And then the child population, we found that more than 18 years of age, the adult population who had early atrial fibrillation before 12 months before enrollment, and who are older than 75 years of age had had a previous transient ischemic attack or stroke or met two of the following criteria. That is age greater than 65 years, female sex, heart failure, hypertension, diabetes mellitus, severe coronary artery disease, chronic kidney disease, and left ventricular hypertrophy. So any of the two criteria listed here, Mr. Chairman, sir. And the trial was stopped at the third interim analysis after a median of 5 years of follow-up per patient. So why it was stopped, Mr. Chairman? That the first primary outcome event, the cardiovascular death, stroke, or hospitalization with worsening heart failure or acute coronary syndrome was significantly lower in the rhythm control group than the usual care group. So that opened the eyes of the physicians that yes, we have to go for rhythm control at the earliest in case of atrial fibrillation. So that is one of the areas which is to be mentioned specialist. And then here we can see, Mr. Chairman, sir, the first primary outcome was a composite of death from cardiovascular cause, stroke, or hospitalization with worsening heart failure or acute coronary syndrome. So after randomization, and we found that the cumulative evidence, usual care had the red line, and the early rhythm control had the lower line. It is a number of risks became lower in case of people who had early rhythm control, Mr. Chairman, sir. So that is very important to understand that rhythm control by direct conversion or antiarrhythmic drugs is very important, Mr. Chairman, sir. So another slide I want to mention. So this is the the summary of the efficacy outcome from that study, and here we can find that the first primary outcome, then also the components which were included: death, stroke, hospitalization with acute coronary syndrome or heart failure, and second primary outcome, nice spend in the hospital, that is duration in the hospital, and key secondary outcome was change in the left ventricular ejection fraction, change in EQ 5D score, SF12, physical and mental score, and change in Morrissey score, sinus rhythm, and the number of patients with picture or total number were asymptomatic. So ultimately, we can find that is very important, and here we can find that many of the features showed a significant outcome, Mr. Chairman, sir. So ultimately, chapter I want to mention, sir, results of this trial support the use of rhythm control to reduce atrial fibrillation related adverse clinical outcomes when applied early in the treatment of patients with atrial fibrillation. Why and effectiveness, and with augmented experience, improvements in patient selection, Mr. Chairman, sir. So I want to conclude here about this part of my lecture, the second part. Then I will move to the third part of my lecture, what I dedicated to be known to the doctors, that is recent updates on SGL2 LT2 inhibitors. That means, Mr. Chairman, sir, that we are treating diabetes mellitus with lifestyle modification. We are treating the patients with oral drugs. We are treating the patients with insulin. Newer additions to treat the patients with diabetes mellitus. But still, we find the patients can have so many complications, especially vascular related complication. The patient can have cardiovascular disease, the cerebrovascular disease, the renovascular disease. The patient can have so many complications. And we know that type 2 diabetes, which affects more than 450 million adults globally, is a major risk factor for cardiovascular disease, I want to mention. So they have got increased risk of atherosclerotic cardiovascular disease, heart failure, renal disease, and death. So these sodium glucose co-transporter 2 inhibitors are a class of diabetes medication approved for treating type 2 diabetes. So here we can find some of the drugs like empagliflozin, canagliflozin, and dapagliflozin have gained traction as preferred agents for type 2 diabetes, owing to the recent discovery that they offer cardiovascular and renal protection in this patient. So for that reason, I have selected this topic to disseminate my knowledge about this drug to my peers. So, what about this SGLT2 inhibitor? So, it is the latest class of antidiabetic medication. So, we know that by simple measures, there is free passage of glucose in the renal glomeruli, and there is absorption of glucose in the renal tubules. But the thing is that this type of drug, they inhibit the absorption of glucose from the proximal tubule of the kidney, and so there is your increased glycosuria. And these are commonly available, as I mentioned, the L2-gliflozin, but I will mention another gliflozin here, Mr. Chairman, sir, the latest one, sotagliflozin, another one. These are commercially available, and another study which has been recently concluded, I will show that result with sotagliflozin, another SGLT2 inhibitor, Mr. Chairman, sir. So why this drug is important, Mr. Chairman, sir? Do they only reduce the blood sugar? No, Mr. Chairman, sir. Apart from glycemic control, there are so many other beneficial effects being observed with this type of drugs, these SGLT2 inhibitors. So, number one, they lower the blood pressure, they increase diuresis, they improve cardiac energy metabolism, they prevent inflammation, they inhibit the sympathetic nervous system, and also along with they increase the weight loss, Mr. Chairman, sir. So here we can find one study that sodium glucose co-transporter 2 inhibitors reduce the risk of hospitalization for heart failure or death from cardiovascular causes among patients with stable heart failure. So this is the question which was put forward, that what is the safety and efficacy of SGLT2 inhibitors when initiated soon after an episode of decompensated heart failure. So in those group of patients, is there any benefit, Mr. Chairman, sir? That was the question. So here we can find that this is a recent publication. It was published in the online. This is on 23rd November. We downloaded this paper. This is sotagliflozin in patients with diabetes and recent worsening heart failure, Mr. Chairman, sir. So a total of 1,222 patients underwent randomization. Randomization included 608 to the sotagliflozin group and 614 to the placebo group, and were followed for a median of 9 months, Mr. Chairman, sir. And this first dose was administered before discharge in 48.8%, and the median of 2 days after discharge in 51.2%, Mr. Chairman, sir. And in patients with diabetes and recent worsening heart failure, sotagliflozin therapy initiated before or shortly after discharge resulted in significantly lower total number of deaths from cardiovascular causes and hospitalization and urgent visits for heart failure than placebo. There was a significant improvement. I want to re-emphasize on this fact because they decided to give the sotagliflozin in those group of patients. Another study, that is randomized trial, which has been done with dapagliflozin, empagliflozin, or canagliflozin, they reduce the risk of heart failure hospitalization in adults with type 2 diabetes mellitus, most without prior heart failure. So that is another question. What is the safety and efficacy of SGLT2 inhibitor when used in patients with existing heart failure with reduced heart failure? So that is reduces the ejection fraction, Mr. Chairman, sir. So we found that in the earlier stage, that in case of stable heart failure, it was very effective, and in patients with your existing heart failure, that is one study result here, and it was published in the New England Journal of Medicine on October 8, and cardiovascular and renal outcomes with empagliflozin in heart failure, Mr. Chairman, sir. And this is called the Emperor Reduced trial. In this double-blind trial, 3,730 patients with class 2, 3, or 4 heart failure and an ejection fraction of 40% or less were randomly assigned to receive empagliflozin 10 milligram once daily or placebo in addition to recommended therapy, Mr. Chairman, sir. Like DAPA heart failure, that is your assessing dapagliflozin, that is it was published in 2019. The Emperor Reduced, that is assessing empagliflozin trial showed that this Nglt2 inhibition reduced the combined risk of cardiovascular death or hospitalization for heart failure in patients with heart failure with reduced ejection fraction without diabetes. I want to mention one important thing, sir, that many of the patients without diabetes but having heart failure, they also receive this empagliflozin, and they showed improvement in their status without having any diabetes, Mr. Chairman, sir. So that is one area that is to be sorted out in our clinical context, in our context of practice. The third area, what I want to mention, Mr. Chairman, sir, the use of SGLT2 inhibitors, whether it is recommended in patients with diabetic kidney disease, what benefit can be given in patients having diabetic kidney disease. So what is the effect in patients with even the non-diabetic kidney disease? Again, I want to mention the people having non-diabetes but having kidney disease, and in patients having chronic kidney disease, they were given dapagliflozin. That is also an original article which is recently published. And here, Mr. Chairman, sir, we can find that is in case of this one in volume 10 in 2020, we found this article that DAPA CKD trial in September 2020. In more than 4,000 individuals with an estimated glomerular filtration rate of 25 to 75 ml per minute, and urine SCR of 200 to 5,000 milligram per gram were randomly assigned to dapagliflozin 10 milligram once daily or placebo. Among patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of a composite of a sustained decline in the estimated GFR of at least 50%, end-stage kidney disease or death from renal or cardiovascular causes was significantly lower with dapagliflozin than with placebo. So I want to mention, very important, it is to be mentioned here, Mr. Chairman, sir, any patient having chronic kidney disease, either having diabetes or non-diabetic, they showed improvement in the GFR or end-stage kidney disease. The decline in estimated GFR became blocked in those group of patients. With this, so what is the final message from this, Mr. Chairman, sir? I want to mention, it is my last slide today. So it is the finding in that study. Approximately 2/3 of enrolled patients had type 2 diabetes, whereas 1/3 had non-diabetes kidney disease. That is very important again, 1/3. At 2.4 years, dapagliflozin reduced all-cause mortality, the incidence of end-stage kidney disease, and the risk of 50% or greater decline in estimated GFR. So it is a very important message to everybody that this is a group of drug which can be used in those patients who are not suitable candidate for renal replacement therapy or having a delay to receive the renal replacement therapy, Mr. Chairman, sir. So that showed a new era to treat those patients, those unfortunate patients having chronic kidney disease with a continuous decline in the estimated GFR. So I want to say about the final effect, that is the beneficial effect of dapagliflozin was similar in patients with diabetic and non-diabetic kidney disease. That reinforces, Mr. Chairman, sir, that the concept that beneficial effects are independent of glycemic control. So that is also again another message that in euglycemic patient or in hyperglycemic patient, in those situations, the patient can have improvement in renal function. And definitely there may be a question whether in euglycemic patient there may be an effect like your hypoglycemia or like that. That was also studied, but there is no effect like this one. Rather, the patients were found that the patient had improvement in the kidney function, and those patients were not having any manifestation of delayed presentation with diabetes mellitus. So with these few words, I like to give thanks to Ms. Moderator of this session, and also Mr. Chairman Sir, Mr. Chief Guest, our Governor General, Professor Chemnadullah San, all our audiences, with my respect to everybody. Thank you, ladies and gentlemen. I want to just switch out, right? Right, I want to exit from here. Okay, I want to go to my where from I went to. Okay, I want to close this one, right?
Yes, sir. Yes, sir.
Okay.
It's done, Professor Azad. It is done. It's closed
Okay,
now.
sir. I want to come in the
Okay, sir.
picture, sir. I want to.
You have shown. Thank you.
Thank you, sir.
Okay.
Sir.
Now, how come? Mom.
So thank you, sir.
Thank you, sir.
Thank you for your very much.
Now, possibly he wants to show something else. Azad?
Sir?
Professor Azad, you want to show something else?
I finished. I want to come to the screen, sir. You can see
you have to answer some queries.
But the thing is that I want to come to the screen. Yeah. Now you can see me in the screen. Just make it larger.
Thank you, sir, for your very informative question. Now we will go to the question and answer session. And I would like to request Dr. Shomishta ma'am to start the question and answer session.
Thank you, sir. So in the meantime, we have got some questions. Our first question, actually he put two questions. Dr. Munadi Al-Islam. His first question is, what should we do if a patient of acute ischemic stroke comes within 4 hours and getting warfarin for atrial fibrillation?
The same thing will be followed in this case, that whether as because the patients having your oral anticoagulant therapy, they are not the candidates. But in this paper, we did not find any information about the warfarin. Definitely, we have to look for the INR ratio. If the INR ratio is a good one, we have to stop this anticoagulant warfarin for the period of your recanalization, and then after 24 hours of completion of this reperfusion therapy, we can restart this warfarin. So we have to stop, then restart after reperfusion therapy if the INR ratio is normal. That is my answer in this question. Thank you very much.
Thank you, sir. Thank you, sir. His second question is, can Nglt2 inhibitor be given to the patients with recurrent UTI and uncontrolled diabetes mellitus?
Thank you very much. But because we know that when there is more glucose in the urine, it invites infection, the fungal infection, the bacterial infection. So definitely before starting Nglt2 inhibitors, we have to check for the evidence of an urinary infection. And if there is a possibility of recurrent UTI, definitely that should be treated early, and that we should go for the treatment, and then we can go for starting this Nglt2 inhibitor, but not before treating the patients having urinary tract infection, and also taking all the measures to prevent recurrent UTI. That is my answer in this question. Thank you very much.
Thank you, sir. Third question is from Dr. Jyoti Das. Some opines that ecosprin may dissolve occlusion and causes hemorrhagic stroke in acute ischemic stroke patients. So her question is, in which type of ischemic stroke, in what size we differ ecosprin?
Well, exactly. That is a very pertinent question because there is a term we call the deteriorating stroke. Deteriorating stroke is to be followed in patients who are having, the continuous worsening of symptoms after being detected by CT scan that he has got an ischemic stroke or lacunar stroke that can expand in size. It can become a very big one that can have your much edema, perilesional edema, that can have a mass effect, and it can have a displacement, that can have a hemorrhagic transformation, and that can have your if the patient has got more hypoxia, electrolyte disturbances, infection. In those cases, there may be deteriorating stroke, and the size can be increased. So, if we see that the stroke size is normal, and otherwise the patient is having stable physical and neurological examination findings, the patient can have your aspirin immediately. So that is a slow process. It can take a much longer time. So definitely after giving aspirin, you have to wait for a very long period for dissolution of occlusion. But the main role of aspirin is that prevention of future thrombus generation. Future thrombus formation is more prevented by giving aspirin. But the thing is that aspirin cannot produce your very much your dissolution of the thrombus. So it has got a very big role in case of your embolic stroke or the stroke with your small thrombi, but it cannot dissolute. So the question of reperfusion came into the picture because aspirin is being tried in case of your ischemic stroke for a long period of time. But so we can see in many patients the disability continues, and there may be more areas of your infarction. So aspirin is not a very good candidate to thrombolize. So it requires your recanalization or reperfusion therapy. Thank you very much.
Thank you, sir. So our fourth question is, in a young patient with atrial fibrillation in limited facilities, what minimum first-line investigations can be done?
Okay, thank you very much. Whatever may be the limited investigation, if you cannot provide the important investigation in case of atrial fibrillation, the patient is to be transferred to a better center by giving some initial treatment with your rate controlling drugs. So the patient must have you should look for the patient whether he has got your hypertension, whether the patient has got a history of myocardial infarction or any type of ischemic heart disease, and whether the patient has got any valvular abnormality, especially mitral stenosis, and whether the patient has got any evidence of your thyrotoxicosis, that is to be looked for, and whether the patient is an aged one, whether any history of your atrial fibrillation in the past. So these are the things to be looked for. And the minimum investigation which are to be done, the investigations for your hypertension, the renal function, the echocardiography, and a continuous ECG monitoring, and the thyroid function test. So these are the important to, in any setting, that is to be looked for your atrial fibrillation. And if it is not possible in an upazila level, so in the district level, you have got the echocardiography, thyroid evaluation, all can be done in those settings. Thank you.
Thank you, sir. So this is our fifth and last question. It is from Dr. Mizanur Rahman. He wants to know about the indication of antihypertensive drug in stroke patients.
Well, thank you very much. This is a very important question that whatever maybe the scenario is this after having a stroke, the baroregulation of the blood pressure is disturbed. the baroreceptor mechanism which controls the blood pressure, so that is hampered. So the blood pressure goes elevated, and it can become your more than 100, the diastolic blood pressure, systolic blood pressure more than 160. So careful monitoring of the patient for 10 days is essential for the reintroduction of baroreceptor control in this patient. So if the patient was not very much severely hypertensive or not getting any antihypertensive medication, you can wait for 10 days by careful observation of the blood pressure. And then you can, if you see that the patient is having normalization of the blood pressure, then you can have a good relief. But if you see the blood pressure remains elevated, or if the patient has got any type of target organ damage, especially any history of vascular events, the ischemic stroke, or the patient can have your ischemic heart disease, the patient can have renal involvement, the patient can have history of heart failure, or combination of comorbidities, the patient having your hypertension, diabetes mellitus, dyslipidemia, obesity. So all this together, in this group of patients, they may require treatment. Or if the patient was getting any antihypertensive treatment, then you can continue that antihypertensive treatment in this group of patients. But a careful observation and understanding the baroreceptor mechanism for controlling hypertension is very essential for the doctors in the stroke ward to initiate or to continue or to stop antihypertensive medication. Because if you lower the blood pressure suddenly, that can increase the site or extent of your ischemia, and the penumbra size is increased, and irreversible neuronal loss may be evident due to hypoperfusion. So a little bit elevated blood pressure may be beneficial in this patient to reduce the size of your hypoperfused neuronal area in the brain substance. Thank you very much.
Thanks a lot, sir, for your very much wonderful discussion. Sir, at this moment, as due to some time constraint, we are not taking any further queries. May I request our today's chief guest, Professor A.K.M. Aminul Haque, Treasurer, ACP Bangladesh Chapter, and Vice President, Bangladesh Society of Medicine, to say a few lines about our program.
Sir, you have to unmute your mic first.
Respected President and learned audience, I congratulate our great speaker, Professor Khan Abul Kalam Azad. He considered the last decade for the current issue and stresses on the early management of ischemic stroke and atrial fibrillation. He also elaborately discusses the management of type 2 diabetes with the recent drug empagliflozin, but we have to consider, though it protects cardiac protection, but we have to consider the serious side effect about perineal infection in case of females. And because we are internal medicine specialist, we have to face many diseases in all aspects of the medicine. So for the time constraint, possibly our speaker considers 3 burning issues, but there are so many other conditions we have to face in this current situation. We have to face COVID-19 pandemic. We have to face the outcome of vaccination, the residual effect of COVID-19. Even dengue is also increasing in our country at this time, also because this is winter season. Bronchial asthma and COPD are also we are facing. So we have to prepare ourselves for fighting all these conditions with our background knowledge. I think the elaboration by our renowned professor, Professor Khan Abul Kalam Azad, we may be benefited if we consider his lectures for Thank you, Sharmishta.
Thank you, sir. Thank you, sir, for your inspiring lines. So, dear listeners, we are almost at the end of our session. May I request today's chairperson, Professor Qazi Tarikul Islam, former Governor, ACP Bangladesh Chapter, former President, Bangladesh Society of Medicine, to conclude the session. Sir.
Thank you very much. It's a wonderful session that we have enjoyed. Though the topic for Professor Khan was very tough. The recent advancement in medicine are huge, but he has selected very intelligently three topics. One is the head office, another is the pumping office, and finally the global burden, that is the metabolic diseases, the diabetes. I think the selection was very good, and the recent advancement is need not to elaborate again and again. But I think this YouTube you will listen many times and you will be benefited. There are obviously, if there are 90% benefit or 80% benefit, there are some risk that he has mentioned, and there is no doubt that how the new approach of reperfusion therapy is done. Well said. A splendid elaboration of that, and I appreciate that once upon a time when we are thinking if these drugs works on coronary artery, why not it is working on the cerebral vessels? But now the time has come that it is really a wonderful one. Regarding arrhythmia, it was wonderful. And one thing I'm sure he intentionally dropped it, that when there is low atrial fibrillation, the cause is not known. If EPS can be done, electrophysiological study, instead of rate limiting, if the patient can come to a very good center like NICBD or somewhere else where electrophysiological study can be done, radio frequency ablation and abortion of the focus can be done. So this is the advancement, and it is available in Bangladesh just 10 years before or 5 years before you could not think of. So these are wonderful lecture that he has said. I think that there was a question from a doctor that at what level we will use what drug in ischemic stroke. Obviously, what Professor Khan Abul Kalam Azad told, that is very right. Do not lower blood pressure, but if it is 150, 90 and above, AC inhibitor, if not contraindicated, is the drug of choice. Finally, last but not the least, SGL2, all beneficial side, Professor Azad told, it is fact and it is the science. You cannot ignore it. But don't forget about the recurrent urinary infection of the women. And a very important information, that euglycemic ketoacidosis. I repeat.
In type 1. In type 1.
Yes, euglycemic ketoacidosis. Don't forget this, because sometimes the patient comes with a metabolic acidotic state, and you are seeing that the blood sugar is normal. Why there is? This is the only culprit drug. All beneficial effect with a very important issue. Being clinician, we should remember. I think we should not discuss a lot. Being chairman, I had to say something. So I must congratulate Professor Khan Abul Kalam Azad for choosing these three topics as a new one, because there are lot of new advancement in medicine, but throughout the night you cannot finish it. But he has chosen very rightly the brain, the heart, and the metabolic status, the diabetes. And the choice of these three was wonderful, and everybody enjoyed it. And I must congratulate our chief guest, moderator, and also Dr. Prince as the program IT expert. Last but not the least, Professor Nazmul Hassan, who is the sitting governor of Bangladesh chapter SCP. I must say that Bangladesh chapter SCP is booming, and it is competing with Indian activities as well as the SCP central activities. And really, it is appreciable. In this COVID time, Professor Nazmul has taken a very courageous decision, health talk. It is not a matter of joke to arrange all these, asking people, then delivering this. Really, this is a tough job, but he has got a very composite attitude, and hopefully we will learn something new in the next session. Thank you very much, our audience, our participants, listeners, that if you can take a single new message today from Professor Khan, that is the success of the speaker. Thank you very much, and I conclude the session here. Thank you once again.
Thank you, sir. Thank you. Thank you, Sharmishta. নাজমুল বাচ্চা আছে
Sadly,
দেখতাম একটু
we
নাজমুল
have
ভাইরে
come to
আমি
the end of
হোয়াটসঅ্যাপে
today's
দেখতেছি
program.
প্রিন্সকে
We have learned so many important things from sir today. Many thanks to Khan Abul Kalam Azad sir, Tarikul Islam sir, Aminul
Thank
Haque
you,
sir,
sir.
and last but not the least from Mr. Madam for managing
Thank
time
you,
for
sir.
this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very important questions. Hope you got your answers. If you joined late or couldn't see the whole program, then there is no need to be worried. You will find the whole program on YouTube right after the live session. Please visit our YouTube channel. Our Health Talk episode 5 will be held on 26th of November, where Professor Mohammad Mujibur Rahman sir will discuss on pictorial medicine, which is a very important topic. See you all in the next episode. Until then, take care. Good night.